This program is brought to you by Emory University.
Good morning, everyone. Welcome to Cardiovascular Grand Rounds. This morning, we're very pleased to have our very own Chandan Devireddy as our speaker. Chandan is associate professor in the Division of Medicine in the Division of Cardiology in the Department of Medicine. Chandan did his initial training in Michigan, his internship and residency at Duke, and then we snatched him after that for cardiology training and have been able to keep him on as faculty after his fellowship training, and he's recently promoted to associate professor last year. Chandan's expertise is in interventional cardiology, and particularly a special interest in peripheral, and has been one of the leaders at this institution and nationally with what he's going to speak about today, catheter-based sympathetic modulation and its potential role beyond hypertension. So, Chandan, welcome.
Thank you. So as Dr. Taylor mentioned, this is a topic of special interest to me, and I'll just kind of go through, and first I'll give you my disclosure slides. I have no financial conflicts of interest with any of the material we'll be speaking about today. I am the site PI locally here at Emory for the following trials, and they're the sponsors. So today we'll talk initially just in general on the pathophysiology and the role of the sympathetic nervous system in hypertension, and then review some of the existing literature behind autonomic modulation and hypertension. Talk then about what's going on now in terms of trials that are taking place currently and will be very shortly, and some new ideas of where this technology may be heading even beyond the scope of hypertension. So this graph, if it's not familiar with you, you're probably familiar with the concept. Hypertension is a worldwide epidemic. This just shows you in graphical format of what this is happening around the world. The U.S. is part of the story, but this is taking place even more dramatically in some developing nations around the world. By the year 2025, it's estimated that we'll have over 1.5 billion people with a diagnosis of hypertension. A little closer to home, this is the latest information from the CDC here in Atlanta. We're living right in the middle of what you can consider a relative hypertension belt, and it's been well established in many studies that the southeast region of the United States for several proposed epidemiologic and other issues is just a hot belt for hypertension. Now, if you look at NHANES data over the past 15 years, we're doing a better job of controlling hypertension, but we're not really doing a great job. And this is information that the MMWR and the CDC put out just last year. So if you estimate here in the US, we have 30% of people that have a diagnosis of hypertension, and of those, almost half are controlled, but just over half are uncontrolled. And those numbers are actually pretty pathetic for a country that would like to think that we're doing a great job in preventive care, but we have a way to go before we get there. Of these people who are uncontrolled, some of it is just an awareness problem, that maybe access to healthcare issues. 40% of people just don't know. But of those people that are aware of the fact that they're hypertensive and are on treatment, 16 million people are just not reaching their blood pressure target goals. So what's the importance of these numbers? It's right here. These numbers that are obtained in a doctor's office on a blood pressure cuff have significant implications for their health status long term. If we talk about just an elevation in systolic blood pressure of 20 points, we're dealing with doubling of overall cardiovascular mortality risk. And those are real events over time that have far-reaching implications in patient health and quality of life. Taking those numbers and reversing them somewhat, if we're able to just achieve a small decrease in systolic blood pressure, let's say 2 millimeters of mercury, then over time we're looking at a 10% reduction in stroke mortality and a 7% reduction in ischemic heart disease mortality. Again, hard numbers that would affect patient outcomes greatly if we could achieve these type of reductions. Now, those patients who are unable to respond to standard medical therapy, those that we consider resistant hypertensives, well, that prognosis goes from bad to worse. So this is data from an international registry called the REACH registry, which looked at patients that had some manifestation of atherothrombosis and followed these patients over time. They had over 53,000 people who had the diagnosis of hypertension. Of that group, just over 12% were deemed resistant hypertensives. And when they looked at these patients over time, their overall cardiovascular risk long-term was elevated over their other hypertensive patients in the population. And looking at it numerically, there was an 11% increase in cardiovascular death, MI, or stroke in these patients. And you can see just by stratifying these patients by the number of medications that they're on, the cumulative incidence of this hard outcome goes up significantly. So how do we define resistant hypertension? And this is somewhat nebulous in the literature. There is one definition that has been kind of used as the gold standard in many studies that have been evaluating patients with resistant hypertension, although the definition itself has some gray areas. The AHA position paper states that if a patient has blood pressure above goal, that being over 140/80, despite 3 antihypertensive agents of different classes at optimal doses, or blood pressure that is controlled but is requiring 4 agents, then these are the type of patients that we consider as quote-unquote resistant hypertensives. Now, they do state in that definition that ideally there should be a diuretic included, and ideally at least 3 of those medications should be optimally dosed as far as the patient can tolerate. Now, if you look at papers that have looked at the prevalence of resistant hypertension in the literature, the numbers really vary widely, and a lot of this has to do with the way they interpret that definition of resistant hypertension. If you take these studies and stratify them for those that include the diuretic portion of the definition, well, there's only 4 of them that included that. And you see their numbers tend to be a little bit lower than the other papers, for ranging from 3 to just under 10%. If we then look at papers that included optimal medical dosing, some of them include diuretics, some of them don't, and again, these numbers are all over the place. Some of them may be due to different patient populations, but a lot of this, at least from the opinion of our group here, is some variation in interpretation of how we characterize and define a resistant hypertensive. So there's even some problem in just how we define these patients. But we do know that no matter what study you look at, these are real numbers, and there definitely is at least a 3 to 20% prevalence of these patients, no matter how you define them. What's associated with resistant hypertension? Well, several things that may be intuitive for most of you: elderly age, increasing BMI, the presence of diabetes, chronic kidney disease, sleep apnea. Now, what the mechanism may be of why this is driving hypertension is varied depending on which literature you look at as far as mechanistic effects, and also African American ethnicity, living in the Southeast, and being of female sex. Now, taking a different tack, the sympathetic nervous system, this goes back to the basic medical physiology. It's the classic fight or flight response that we all know pretty well. These nerves are a little bit different than the nerves that control skeletal muscle. They're continuously active, constantly monitoring physiologic systems to maintain homeostasis at any given point in time. But we do know through various epidemiologic studies as well as mechanistic studies that alterations in the function of the sympathetic nervous system is felt to play a role in several disease states, as we'll talk about a little bit later in this talk. Specifically, in regards to hypertension, it is felt that possibly as many as 40% of hypertensives may have some dominant contribution from the sympathetic nervous system as far as the incidence of hypertension, and it may have even more of a role than previous physiologic models have suggested. This is just a cartoon format, and some of you may be familiar with this slide of how the sympathetic nervous system is controlled and its role with the kidney. These signals come from the posterior hypothalamus, and in the role of efferent nerves that come directly and innervate the renal end organ in various places in the afferent and efferent arterioles, the juxtaglomerular apparatus. The kidney is richly innervated with sympathetic nerves, and there's various functions that take place as a result of this stimulation. Activation of the renin, angiotensin-aldosterone axis is one of the main physiologic players in pathophysiology with hypertension, thereby leading to sodium retention and decreases in overall renal blood flow. Now, innervation from the brain to the kidney is not a one-way street. The kidney also has its own afferent nerves that then travel back to the hypothalamus and signal in ways that modulate a very complex interplay and feedback loop between various organs. There has been a rich set of data, a lot in animal models, that have shown that this afferent stimulation from various factors such as renal ischemic stimulation, increases in adenosine and decreases in overall perfusion of the kidney, can thereby modulate signaling to the heart and may regulate the incidence of left ventricular hypertrophy, endothelial dysfunction, possibly even arrhythmogenesis, and also may play roles in various other organs such as the pancreas, in insulin resistance and diabetes, and various other disease states which are now being further investigated. The story of our ability to tackle elevated blood pressure has been one of recent time. Before the 1930s and 40s, there really wasn't much in the way of options. And then from the 1950s onwards, we've seen a proliferation in our ability to hand a patient a prescription or enter one in the computer and have these patients have the ability to tackle this blood pressure, which before then really was not an option. But if we think back in time to before this pharmaceutical revolution, there really wasn't much, and one of these options was a sympathectomy surgery. And back then, this was a fairly morbid surgery, but the data was followed very closely. This was the overall survival rate of a patient in their 40s at that time. And then they stratified these patients based on their overall hypertensive burden with increasing end organ manifestations of hypertension. And then they took the same types of patients that had this surgery and followed them over time. And their overall survival rate, forget about other cardiovascular morbidity, but just looking at overall mortality, was cut fairly significantly. If you look at such as group 3 and group 3 here, almost cutting their mortality in half. And similar types of responses to other groups. This led, at least short-term at that time, to an increase in performance of the surgery, but it fell to the wayside by the 1960s because of increasing recognition of the morbidity of the surgery, plus the availability of very benign or relatively benign pharmaceutical options, which essentially drove the surgery into the ground. But the physiology was well recognized at that time. In a perfect world, if we could do this in a way that was much more comfortable and minimally invasive for the patient, we would like to target the specific nerves, at least from the standpoint of renal denervation, that just innervate the kidney, which come through several ganglia coming from the lumbodorsal sympathetic system and richly innervate the artery and are typically present right around the adventitia. So with the advent of advances in minimally invasive catheter-based technology, this story started in the last decade, first with a device called the Symplicity system, which was designed to be compatible with the same types of sheaths and catheters that we use for coronary and peripheral angioplasty. So this is a 6 French system for those that are familiar with catheters. A flexible tip was initially devised by a small startup group here based in the US and connected to a portable generator which monitors the amount of energy and heat being delivered at the tip of this electrode. This is just a unipolar electrode with 5 to 8 watts of energy delivered at the tip. This is an example of how we do this procedure. We first demonstrate what the renal anatomy is. Up to this point, this is all investigational in the US and has only been able to be performed as part of research trials. So before we could do so, the presence of anything out of the ordinary with kidney anatomy was excluded. The presence of accessory renal arteries or any renal artery stenosis, essentially more than 50%, was an exclusion. This is a patient that is an interventionalist's dream as far as this procedure, wide open, juicy renal arteries. We take a selective angiogram. And then on the other side, again, no significant disease, just one primary artery to the kidney. And then we take this catheter, which has, again, this distal electrode tip coming back at least 5 millimeters from the bifurcation. And each of these treatment times is exactly 2 minutes optimally. We then perform this denervation with focal treatments, ideally coming back in a spiral pattern, coming back proximally to the kidney. As you can see, we're trying to denervate in different locations at each time. And usually at the ostium, we try to end with a more superior location with the thought that there may be a higher density of these nerves at the renal ostium superiorly. That's the last treatment in that artery. Going to the contralateral side again, starting distally just before the bifurcation, and coming back in a spiral pattern. You can see the electrode marked by that tip. And again, trying to vary the location of these burns, if you will, to try to maximize the chance of catching different fibers for the optimal treatment effect. So this Symplicity catheter began a fairly robust set of clinical trials that were all initially based outside the United States, first with some first-in-man experience, and then with both the Symplicity HTN-1 and HTN-2 clinical trials to investigate its effect in blood pressure lowering in resistant hypertensives. After the HTN-2 trial was published, there's been a broad range of interest outside the US market. There is a large Symplicity registry going on, which is a global registry. There's a Symplicity heart failure study going on, some interest in sleep apnea and diabetes, and now with diastolic heart failure, a real explosion in interest in this technology in various disease states. Here in the United States, we've been limited so far to the Symplicity HTN-3 study, which was technically an ongoing clinical trial for phase 3 approval for the US market, and an HTN-4 study, which is in the planning process. And I'll talk about these studies in more detail later on. So going back to the beginning, HTN-1 was first published in Lancet in 2009. This was a small, there was one first-in-man case reported, but this essentially was the first-in-man non-randomized experience. Small group initially of 45 patients, then an expanded cohort overall. They were looking at patients that were the worst of hypertensives. Systolic blood pressure is over 160 on at least 3 antihypertensive medications with relatively normal kidney function. You can see the average blood pressure here was over 176 despite those medications, so a fairly hypertensive, morbid group of patients. On the usual medications that we would anticipate treating, with the exception that the use of spironolactone was somewhat low. Now this is the latest follow-up data in that cohort, and they have long-term follow-up in some of these patients. If you go out to a year, the change in systolic blood pressure was lessening by 26 points systolic. In a smaller group going out now to 3 years, the blood pressure lowering, at least in that group, appears to be sustained at over 30 points systolic after having undergone this renal catheter-based denervation procedure. So that study led to Symplicity HTN-2 with fairly similar inclusion-exclusion criteria, a little bit difference in the systolic blood pressure in patients with diabetes. This was generally outside in Europe and Australia. This was randomized, but not to a sham procedure. It was randomized to a control office-based hypertensive population. Again, inclusion criteria are very similar. Blood pressure systolic was over 160 on at least 3 medications. And the exclusion criteria that you would expect: no significant renal disease, no prior renal atherosclerosis. And baseline characteristics, again, very similar. Systolic blood pressure over 175 on average, despite taking all these medications. On average, these patients were on 5 medications, and again, generally similar to what we would treat with here in the US, with the exception that the use of spironolactone or eplerenone, again, was very low, and this has been one criticism of these trials. And this was the final endpoint of that study, which really generated this explosion of interest around the world now in the use of this technology. So the 6-month office-based blood pressure was a primary endpoint, and for those patients who were randomized to the denervation treatment group, had a drop in their systolic blood pressure of over 30 points systolic, with no change at all seen in the control group over the same period of time. If you define response to this treatment as a greater than 10 millimeter reduction, then 84% of patients were considered responders in this trial. Now there is longer-term follow-up data that is available now. This was presented at the ACC last year. So for those patients who had undergone treatment and had that drop of 32 points systolic at 6 months. If you follow those patients out to a year, their systolic drop was essentially sustained at 28 points, reduced from their initial baseline presentation at day 0 at 12 months. They then took patients in the control group, and for those patients who still met all of the original inclusion-exclusion criteria, they then crossed them over to receive catheter-based denervation. And when they took those patients and followed them for 6 months after undergoing this treatment, they then experienced a drop in the systolic blood pressure of 24 points systolic. So a fairly impressive drop. Definitely something going on here in this group, whether it's a true treatment effect or placebo effect, depends on who you talk to, but fairly impressive drops in blood pressure seen after being assigned to a renal denervation group. There was no change at all seen in patients' GFR or renal function, no matter how you measured it. And as far as safety events, there's in these trials been no evidence of any catheter-based dissections, trauma, or proliferation of atherosclerosis at the sites of renal denervation. So those studies finally led to Symplicity HTN 3, which is the only study in the United States so far which has allowed operators and sites to perform this procedure in resistant hypertensives here on our shores. We were fortunate to be one of 90 sites to be selected. We were the first in Georgia to be activated to participate. We're hoping that this data will be available to us in early 2014. The final patient visits should be concluding by the end of this calendar year, and it will be very interesting to see what the results are of this study, because this study scientifically is much more rigorous than the studies that have been performed so far that I've shown you. And the major reasons for that is that, number one, the sample size is much larger at 530 patients. There's a fairly rigorous screening process required before randomization. And the randomization was to both a treatment group and to a true sham procedure group. So this was with the intentions of eliminating any placebo effect of being told that they're in a catheter-based treatment arm and potentially just, being happy about it and being followed in a medical clinic and having their blood pressure lowered from that standpoint. These patients are followed for 6 months and will be followed long term. And our hope is that despite having a much more rigorous approach as far as randomization, that we will still see some treatment effect in those patients. But again, that data is forthcoming, but it has led to an explosion of interest outside the United States. And there are already several devices that are already CE marked for renal denervation for clinical use. This has actually been taking place for over a year now, as close as Canada and Mexico, as far as patients receiving this procedure. So some competitors that are hot to trot to get into this market, number one is the Vessix V2 system, which has been acquired by Boston Scientific. And this is a balloon-based technology as opposed to a catheter-based technology. And this balloon has various electrodes that are arranged in a spiral fashion around the balloon. The treatment time is fairly low, just 30 seconds for each therapeutic application. The energy delivery is felt to be lower because of a bipolar arrangement. So the initial data that's been available this is all unpublished. This was just presented at PCR in this past year, called the Reduce HTN trial. This is essentially their first-in-man experience. And again, the numbers are very similar to what's been seen in the Symplicity experience. If you look at these patients, and this is a small group, just 40 patients overall, their 6-month systolic blood pressures again have dropped at around 27 points systolic. They have a small group that has 12-month data available, and the blood pressure reduction again has been sustained at 28 points systolic. Another competing technology soon to come to U.S. shores is the Enlighten catheter. This is a St. Jude medical device, which again has multiple electrodes. It's not balloon-based. It's actually a catheter which has an expandable basket which opens up once in the desired location within the renal artery. This treatment time is similar to Symplicity in that it's 90 seconds per electrode with 4 electrodes that are in rotational fashion in different distances along the basket. A fairly atraumatic tip, a little bit of a larger device. It is 8-French compatible and can only be used with their generator. They also have presented their 12-month clinical data in their first-in-man experience in the Enlighten-1 study. This was also presented at EuroPCR. The overall response rate was fairly impressive, similar to what was reported in Symplicity of an 80% response rate as defined by a drop of at least 10 millimeters mercury. If you look at the blood pressure group in 45 patients, after 6 months, again, a systolic drop of 26 points. So very consistent numbers. Again, whether this is real or placebo effect, we'll have to see, but it's getting harder and harder to say that this is all just a matter of chance or placebo effect, as these numbers are both impressive, but also in a range that has been fairly similar across the board, at least in all of these early experience clinical trials. Going out to 12 months, again, the blood pressure drop has been sustained. As a result of these type of results, renal denervation and modulation has been an extreme focus of bioinnovation for new devices that seem to be exploding over the past year. There's probably 40 to 50 small startups that are in this space in some way. Covidien has their variation of a balloon, which actually has sort of a spiral electrode that wraps around the balloon. They have their own trial going on right now outside the US. Thinking of this from a different tack, there is a small company called Recor, which has a balloon which actually has its own little self-cooling mechanism and delivers therapeutic ultrasound to try to treat the renal sympathetic nerves. A similar device from a group called Sound Intervention has therapeutic ultrasound delivered almost in the way that we look at rotational IVUS, in that there's therapeutic ultrasound that is delivered in a spiral fashion. And their claims are to maximize the amount of surface area that gets affected with this therapeutic effect, and also potentially in a way that's less injurious than an actual heat-delivered thermal injury from electrical denervation. Probably one of the more interesting concepts, and this also is going through their first-in-man experience, is a group called Kona Medical, which is looking at the application of external-based ultrasound to therapeutically denervate all of the renal nerves that lie along the adventitia, with the idea that a patient could walk in, lie on a table, you deliver this therapeutic ultrasound externally, and the patient walks out without any type of catheter-based innervation whatsoever. Their first generation of the device does involve placement of a wire inside the renal artery, I think for some spatial localization of the treatment, but that's in the works too, which would be very exciting if that were to pan out as well. And again, there's a lot of other companies that are variations on theme. These are the ones that are probably some of the closest that are involved with clinical trials outside the US currently. But before getting you all extremely excited and you're ready to go out and send patients for denervation today, I do want to play devil's advocate and try to be as unbiased as possible, although I am biased being an operator that's involved with this. Is some of this data too good to be true? I present this slide as sort of the opposite side of the legal bench to say, some of this may be a little bit getting ahead of ourselves. A lot of this clinical approvals and startups have been based on European data that is limited in several ways. All of these trials have been unblinded randomizations with no sham procedure whatsoever. So we're comparing office-based hypertensive patients to patients that are well aware of the fact that they've received something very different than their control group counterparts. And how much of a placebo effect is possible at that? Well, we're going to have to wait and see what the US study shows. Another problem is, how do we define resistant hypertension? All of these trials have left that definition somewhat to the discretion of the investigators and the operators. And operators sometimes have a fervor to include patients in trials, and whether these patients could have been more maximally treated with medications? We probably will never know because that was not part of the methodological criteria of the studies. There was no dose titration or mandates to document that patients had been pushed harder on their pills or tried on spironolactone. None of that was included as part of the trials. Now, as a result of the selection criteria, these were also selecting really the worst of the worst hypertensives, patients that had blood pressures that were out of the stratosphere despite multiple medications. And you would expect more of a treatment effect in these type of patients. But as this technology gets approved in different markets, will we see the same clinical effects in patients that we see in our bread and butter hypertensive practice? There has been some data in single center experience in Europe which have looked at ambulatory blood pressure monitor data in patients coming in, and again it's just one or two studies, single center, but there's been some suggestion that some centers have seen possibly a less robust clinical effect, especially when using ambulatory blood pressure monitor data as a way of monitoring this. So that will also be of interest because ambulatory blood pressure monitoring is mandated and included as part of the United States HTN study. So we will have all of that data for every single one of the patients that is included here in the US. Again, I mentioned there was no requirements to document how well they were treated. There was also no requirement to document whether they had had any underlying secondary hypertensive etiology. Could some of these patients have been hyperaldosteronism patients or hypercortisol or had some other secondary hypertensive etiology that could have been worked up and treated? I do state that follow-up is limited, and for the most part it is. The 18-month and 36-month data, those subsets are much smaller than the populations that were initially enrolled in the 6-month experience for all of these trials in the beginning. One problem that we've felt personally is it's very difficult to define resistant hypertensive status in patients that come into clinic, and this was data that we actually just published recently in the past month. A very enterprising group of, at that time, residents, and now many of them are actually I think all of them are cardiology fellows, many of them here at Emory still. And we went through and looked at all of our hypertensive patients that came through the Emory University Hospital Midtown Emory Clinic campus and stratified them based on differing interpretations of how you define hypertension. And if you look at a very lenient definition by just looking at how many medications they're on, well then you can estimate that 30% of people are resistant hypertensives in our practice. But when you get more specific and include diuretics and mandate that patients are maximized to the maximum limit of a hypertensive dosage, then this definition drops as low as 3%. This is exactly the range that we saw in that initial slide showing all the studies that have looked at the prevalence of this diagnosis in the past. So how much of this is just due to variations in interpretation of the definition? We don't know, but this is at least with a small group of patients, just over 1,700 patients in the Emory Clinic population here. We then looked a step further and said, well, if you look at that same population of hypertensives here in the Emory Clinic, how many of them would be candidates for renal denervation if you apply the criteria of the Symplicity HTN study? And that number was infinitesimally small compared to the amount of patients that have controlled blood pressure. 0.8% of patients would be candidates for the trial, and this is very much the experience that we had in our ability to recruit patients for this study. We had hundreds of patients that came to us over the past 2 years trying to get into this HTN study, and we were only able to randomize a few. I can't give you specific numbers since the data has not been released, but it was a very difficult study to be accepted into. So there's definitely some bias in selection for these patients, as a very few number of patients would qualify. And if this technology is approved for clinical use in the US, as it already is in Europe, the thought is there going to be the same degree of benefit when looking at these hypertensive patients, which are much more prevalent in our clinic populations? And that's where the enthusiasm is going to be to apply this technology to those patients. And it behooves us to try to obtain data in these patients before we see an explosion in the proliferation of this procedure for patients where there's been no data to suggest benefit. Now, if, on the other hand, this technology does prove to be of benefit, what could it potentially do in the long term? And this, in my mind, is sort of a best case scenario. This was sponsored by Medtronic, was published in JACC, and essentially was a cost effectiveness analysis looking at assumptions of what potentially could happen if the benefits of the Symplicity HTN-2 trial were seen and were projected out 10 years. And if you see that degree of blood pressure reduction over a 10-year period, you're going to see a fairly significant reduction in hard types of variables: mortality, stroke, and ischemic heart disease, heart failure, hospitalizations. So they took what was estimated in the literature of the benefits of reductions of systolic blood pressure by that degree, and then looked at costs that would be saved by reducing the incidence of new dialysis, hospitalizations for heart failure, stroke or MI hospitalizations, and estimated a reduction in mortality in a denervation group over the 10-year horizon, and actually saw a lengthening of life by several years in patients that underwent denervation. Again, this is all projected calculations. And they calculated just over a $3,000 quality adjusted life year benefit from having undergone renal denervation to prevent some of these outcomes. If you use dialysis as a similar benchmark, which is essentially the benchmark that we use for all new technology that comes out here in the US, that benchmark is set at $50,000 for the benefits you see in dialysis patients for the cost of $50,000 per quality adjusted life year. Now, the caveat I would put is that the numbers seen in HTN-2 were office-based. We're probably a little bit on the higher side of other trials that have been done, but again, all these trials have shown office-based reductions of 20 or more points in the blood pressure. If those numbers pan out, we really could see significant reductions in cardiovascular morbidity, in nephrologic morbidity, if you would, on dialysis. And this is what will have to be shown long-term to justify what will be a very high interest in proliferation of this device, both by industry and by proceduralists. Now, really going beyond the concept of hypertension, there's been a lot of interest in renal denervation in other disease states. And I'll touch on this quickly. There was a small study done, just a pilot study, looking at renal denervation in patients with severe chronic kidney disease, stage 3-4 chronic kidney disease. This is not really a randomized group. It was just patients that were done and followed. And as documented in all of these other trials, these patients had fairly impressive reductions in the systolic blood pressure. I'm not sure if you can see these numbers, but drops in the systolic blood pressure of about 30 points on average when you're getting out to 6 months. But these patients also had, interestingly, no worsening of their GFR. And they also had improvements in various biomarkers that were measured, measurements of endothelial dysfunction. So a very significant area of interest, because chronic kidney disease patients have such upregulation of their sympathetic tone, is whether renal denervation will have clinical benefits, both from the standpoint of blood pressure lowering, but also from other physiologic factors as well. This is a sub-study that was done as part of the HTN-2 trial, which looked at the diabetics that were included in that study. And patients who underwent denervation, and these are in the gray bars here, across the board in this sub-study had improvements in markers of glucose tolerance. This right here is the overall fasting glucose numbers. This is changes in fasting insulin, changes in C-peptide. Across the board, patients that underwent denervation, again, small sub-study, all seemed to tolerate glucose better than their control group counterparts. So whether there is some crosstalk between the kidneys through renal artery sympathetic nerves and the pancreas remains to be seen, but these studies are in the planning phase. Another sub-study that was published in JACC last year, looking at patients that had echocardiographic evidence at baseline with evidence of LVH, and then followed these patients over time. Across the board, the measures of left ventricular mass index, patients with denervation are in the red bars compared to their control group in the blue bars. Septal thickness and their overall reduction in left ventricular mass index, there was statistically significant drops in the burden of left ventricular hypertrophy and the thickness of the septum in patients who had undergone catheter-based denervation in numbers that really blow away pharmacologic data with ACE inhibitors or ARBs for similar type of endpoints. But again, this is very early phase sub-study data, but based on this data, there are a number of studies, both in Europe and in the Asia-Pacific theater, that are looking at heart failure as a potential treatment population, as well as heart failure with preserved ejection fraction, which I think will be a fantastic area of study. But again, in the US, we're limited and we can't look at this technology outside of hypertensive so far, but all the studies are in the active planning phase and will be enrolling soon outside the US. An interesting study conceptually was one done in conjunction with a group from New York as well as Siberia, which randomized patients with the randomized patients that were going to undergo atrial fibrillation ablation to an AFib ablation alone, to an AFib ablation plus a catheter-based renal denervation. In these patients that underwent catheter-based denervation, the drop in systolic blood pressure, again, was very similar to what was seen in the other trials, drops of about 20 points systolic. But when you looked at the patients from an atrial fibrillation standpoint, the patients that underwent pulmonary vein isolation plus renal denervation had a higher chance of being free of atrial fibrillation going out to 12 years. Interesting conceptual data. It does suggest that the sympathetic nervous system may play some role in driving the perpetuation of atrial reentrant arrhythmias, possibly. This is all, again, hypothesis generating. There have been sub-study data looking at Symplicity patients and other single center studies in Europe which have looked at heart rate data and have shown improvements in resting heart rate tone in patients that have undergone denervation, and again, will bear out in larger studies that will be done forthcoming. An interesting study that was actually just published in JACC this past week, or the week before, addresses the question of whether this can be done in the pulmonary arteries. So this group is a Chinese group which originally set up an animal model in Mongolian dogs, and in their initial animal model had essentially created what they thought was a pulmonary hypertension model through tying off one of the renal arteries. And the dogs that underwent pulmonary denervation, quote unquote, had some protection in the development of this pulmonary artery hypertension. So they went from their animal model to human patients with patients that they deemed as idiopathic pulmonary hypertensives and actually underwent bilateral pulmonary denervation with a catheter that they've devised themselves. It's a loop catheter, first going from the left, as you can see here, and then over to the right, PA. And their numbers were very surprisingly impressive. Now again, this is a very small group of patients. I think this was just in the order of about 15 patients. Initial pulmonary pressures you can see here in the 80s, and then following up, this dropped down to just about 70. Pulmonary vascular resistance significantly dropped. RV pressures, similar changes you can expect. Central pressures were surprisingly low in these patients. This study has generated a lot of interest around the world, but a lot of criticism as well. It's a very preliminary proof of principle study only, tiny study as far as sample size goes. And there are a lot of unusual factors in these patients. When we think about pulmonary hypertensive patients, we're usually thinking of female patients. These patients were predominantly men. Their hemodynamic variables were a little funny for patients with true idiopathic pulmonary hypertension. It was unclear what type of medical regimen they had been on. They just didn't seem to be representative of the usual clinic-based pulmonary hypertensive population that are seen here in the US. But again, this may generate further studies to investigate this, but mechanistically, at least for me, I'm a little bit suspicious just because it's the process of pulmonary hypertension and this distal fibrosis seems a little different than you would expect to see this instantaneous effect. But again, there were a lot of naysayers with the arterial denervation in the renal bed to begin with as well. So we'll see how that story pans out. Thinking of alternative approaches for neurohumoral modulation, this treatment effect is not limited to the kidneys. There is a company called CVRx which developed a system for surgically implantable leads to be wrapped around the carotid bodies, which can then be attached to a generator which is implanted with leads that are tunneled to these electrodes, with the ability to really ramp up the signaling of the carotid bodies. They had a study that was published in JACC just over a year and a half ago, which showed sustained blood pressure reduction with some questions of LVH regression. Now, they had several endpoints that were pre-specified. They met 3 of them: their long-term efficacy, long-term device safety, and short-term therapy safety, but they did not meet on 2 endpoints: short-term efficacy and adverse events with the procedure, as you can imagine, by cutting in the neck and wrapping electrodes around the carotid. But the blood pressure reduction long-term was significant, so it does demonstrate treatment effect, and this group has not gone to the wayside. They have developed a smaller lead, as you can see here, in what they call the NEO system, and a smaller generator, and these studies are ongoing outside the US to see if they can reduce those morbidity numbers and have the same type of sustained blood pressure reduction numbers. So thinking along the lines of the same pathophysiologic principle, there are some upcoming studies both looking at this mechanism as well as trying to push the knowledge base of renal denervation further. So from the standpoint of renal denervation, Symplicity HTN-4 is an upcoming study which will be very similar to HTN-3. This study will be looking at moderate resistant hypertensives, if you will, with a blood pressure cutoff that will be less than what was included in the original HTN-3 study, systolics of 140 to 160. For those of you who tried to refer patients to Symplicity, I'm sure a lot of you were frustrated in that the criteria were just so strict and that many patients were excluded. We do hope that this blood pressure cutoff will allow for a much easier time in enrolling patients. This will be a similar randomization we expect. Again, there has not been a protocol that has been released formally. We do expect it will be a likely single blind again, but with the patients being blinded. We will be one of likely 100 sites nationwide that will be participating, with Midtown as the coordinating site, and we're really hoping that we'll get cleared through regulatory and be enrolling within the next few months. St. Jude, as I described earlier, has their Enlighten catheter. There is a phase 3 study that will be starting in the US soon. This is a multi-electrode catheter with a protocol that we envision will likely be very similar to HTN-3. Again, we haven't seen the protocol. I can't tell anything about it in detail, but likely will involve hypertensives with a blood pressure cutoff of over 160, just like HTN-3. We do expect this will be randomized, and again, Emory will be participating. Midtown will be a coordinating site, and again, I'm really hopeful that we'll be starting in the next few months because we are getting patients that are getting referred and they have no place to go right now unless we get these studies opened up. Looking at this from a different standpoint, there is an interesting study. This has been spearheaded by Javed Butler. This is all very preliminary. I cannot tell you any details about this, but the Heart Failure Clinical Research Network is planning a PRESERVE study, which will be a small-scale mechanistic study looking at renal denervation in systolic congestive heart failure. Very exciting idea. Emory University will be one of only a handful of sites participating in this nationally. And again, hopefully this will be initiated. The coordinating site will be here at Emory Clifton campus soon, and I'm very excited about this. Thinking of autonomic modulation from a totally different standpoint, this is actually an ongoing study. Some of you may not be aware of this. This is called the CALM First in Man study. This is a new device called a Mobius HD, which is a novel catheter-based endovascular implant to be placed in the internal carotid for carotid body stimulation for the same therapeutic effect that the CVRX system is chasing down. Interestingly, this is part of a new FDA pilot program where the FDA in the past year has said, look, we've gotten a lot of criticism that all of this new technology experience is happening outside the United States. Let's try to bring some of this back to the US. So there are just a few industry awardees that were allowed to participate in this to actually design a first-in-man study with the FDA from the beginning to do first-in-man work in the United States. So we were actually the first site to be activated as part of this study sponsored by a small company called Vascular Dynamics. I can't show you anything of what the device looks like because of their proprietary interests, but I have exciting news that Emory was the first in-world, first-in-man site to actually deploy this device. This is a press release just from the end of last week where we finally announced that we did this. We're one of 5 anticipated sites in the US. There's a few sites in Europe. We were kind of in a race to try to do this procedure. We were the first in the world to implant the device. I can't tell you any specifics about the procedure and the patient other than the patient has fulfilled a 30-day visit and is doing well. And we're very excited to look at the experience with this device further as we go into the study. So if there's any interest in referring patients for this, we'd be excited to talk to you. And hopefully we'll be taking a leadership role with analysis of this device and its potential benefits. So where do we move in the future with this? Well, we're anxiously awaiting the results of HTN 3. I think that study is going to make or break this technology in the hypertensive realm, just given the design of that study. There's a lot of innovation and competition fast on the heels of Medtronic's device, which I think is a good thing. Some of these devices have benefits, as I've talked about, in multiple electrodes, shorter treatment times, and those studies will be beginning soon. Emory will be a site. We'll be very interested to talk to folks that have patients that they may think may benefit. Long-term implications have not been discussed as much in the literature, but I think are important to think about. Is there the possibility of reinnervation? Are there potential downsides of undergoing this type of treatment? Will patients potentially be more at risk of orthostatic hypotension if they undergo this treatment? And all of those answers are going to have to bear out with the larger international registries that are being performed, as well as these larger trials that are being done in the United States. We'll have to look mechanistically to see if there's broader pathophysiologic applications of this technology to other disease states. Some of this is being done now. HTN 4 will be looking at moderate hypertensives, studies looking at diabetes, different forms of congestive heart failure, and chronic kidney disease and atrial arrhythmia as well. So on that note, I will end there. I thank you for your attention. If there's any interest, that's a phone number for our coordinator, or feel free to email me at any time. I'm always happy to take questions about this area of medical science. Thank you very much.
Thanks, Chandan. We're going to take questions locally, and then remotely you can either use the WebEx application or use Twitter. So I'll start out with a comment and a question. So I guess the other mechanistic thing to think about is the interaction between the sympathetic nervous system and the inflammatory system, and just that there has been quite a bit of data about activation of T cells and sort of the general inflammation, modulation of inflammation. So I think that has some broader implications too in terms of disease. My question for you is one sort of about the healthcare economics of this, and you presented the one cost analysis, and as you pointed out, the first thing that sort of happens when a new technology is available broadly is people start generalizing the impact or generalizing the use of that technology and start applying it in patient populations that the original tests were not performed in. So this is done in a very select group, as you point out, and the vast majority of these patients are not in that group. So I was wondering, in terms of the cost effectiveness, have people done sort of a broader sensitivity analysis at the more moderate hypertensives, or at least what are your thoughts about that? Because that's going to be where the economic burden is and where the benefit might be less.
Very interesting point you raise, and I think what we're talking about is indication creep. We approve a device for one indication, and then we kind of go outside the labeling and pursue other types of patients. I think it's going to be very interesting to see if this HTN-3 study is positive of what CMS and FDA does with the data. Are they going to mandate, because it's so easy to cherry pick a blood pressure cuff measurement. I walk in I walk in a clinical office with a white coat, or any of you walk in with a white coat, and that patient's blood pressure is already going to go up. Pseudo-resistance is a well-established phenomenon. And all I got to do is, ask a patient, well, tell me about your boss. Tell me about your kids, and boom, your blood pressure's going up. There's ways to game the system. So I think if this device just gets cleared for an office-based blood pressure, there could be tremendous abuse in the system. So I think, I know there's interest with the FDA and regulatory bodies of how to approach this. There's actually a roundtable discussion taking place in Bethesda next week with some of these parties to try to discuss some of the issues, to anticipate what may be involved. But I don't know how they're going to restrict the use. Are you going to mandate a secondary hypertension workup, or specific types of hypertensive centers? And there will be a lot of pushback from industry because they want to, proliferate this as widely as possible. That's in the interest of their shareholders. So it's, I think, going to be on the part of responsible physicians and regulatory bodies to try to control this, because I think my bias, I believe in this technology, but I want to use it if it works. But if it gets out of hand and the pendulum goes the other way, then there may be patients that actually miss out that could potentially benefit.
Thanks. It's a great study. Great work, Chandan. The thing that struck me was the absence of biomarker data with regard to changes in activity of the renin-angiotensin system or the sympathetic system. That's my first question. Is I presume the data has been done. It's not quite as dramatic as the clinical data, and that's why people aren't talking about it. Second, but I wondered what the real information is. Second question is that as surgeons, we see what radiofrequency does when we burn the atrium to create lesions. And that burn is essentially the same as taking a flaming match, blowing it out, and holding it against your skin. It's a white, full-thickness burn spot on the atrium. And that's what radiofrequency is. It's a burn of the renal artery. And what is the data relative, in both animals and humans, relative to future changes in that artery?
So biomarker data has been very limited in these larger studies. They've tried to limit their outcomes data to just the clinical blood pressure endpoints. I think it would be nice to see more of that. We had proposed some secondary biomarker sub-studies, and a lot of that was turned down, I think, for fear that some of this data that's taken outside the original protocol may be looked at by the FDA, and there may be problems in getting to market. There's, I think, data on both sides. I think there's a lot of animal data that suggests that alterations of the sympathetic regulation in hypertensive models do show improvements in various biomarkers, but it depends on which study you're picking. In these patients in particular, I think it will behoove us to try to do more of that work as we expand our clinical experience with it in human patients.
It at least might direct your medical therapy that's adjunctive to the
correct. And maybe another thing I didn't really touch on for the interest of time is patient selection. There's no way that's been shown, except for one or two studies that have suggested some ways of how to select the true responders. Some have looked at some of these devices and measures of continuous blood pressure and ECG recordings to look at potential autonomic dysnomia, if you will, and picking patients that have some evidence of autonomic dysregulation, and there may be some better ability to choose patients, but it has not been done so far based on markers of inflammation. To answer your second question about injury with radiofrequency ablation, you're absolutely correct. Now, on the flip side, there have been a number of imaging sub-studies, whether it was duplex, CT, or MRA, and all of the sub-studies with these studies have so far never shown a patient that has experienced either dissection, perforation, trauma, or initiation of atherosclerosis at a site of denervation. Now, outside of these studies, there was one small study which looked at, I can't remember if it was IVUS or OCT data, looking at the renal arteries after application of radiofrequency energy, and it was much more close to what you're describing, that you can in real time see these kind of pock marks, and we see these when you kind of like you'll see cobblestoning of the renal artery. You'll see a lot of spasm. It's definitely a profound injury. But the thought in the industry groups that are developing these is that the renal artery has been able to rebound from that, heal in a way that has not affected overall caliber of the vessel.
Do you have 3-year angiographic or MRA data?
Absolutely not. So
That's
you're
scary.
right. So we don't have that type of follow-up. It's all been based on 6-month angiographic data. So, before the horse gets too far out of the barn, I think the points you're raising are very valid. We don't totally know what is going on in some of these patients, both in a physiologic standpoint and in a local anatomic standpoint. The OCT data showed evidence of platelet clumping, which you would expect with local injury, and whether these patients would need to be on antiplatelet agents to protect the distal renal bed. Nobody knows. No one's done that kind of study. So there's a lot of questions that are good questions you're raising that I think are going to have to be borne out.
Yep. So, Chandan, I just want to congratulate you for a really balanced presentation. I mean, it's a very exciting technology, and I thought your presentation raised a lot of appropriate points of skepticism, but it is extremely exciting. So my question to you is with regard to the technique, are there other technologies besides RFA like cryo and ultrasound guided that people are looking at, and also with regard to just shortening the procedure, just concentrating on the ostium of the renal artery rather than ablating the whole artery?
Sure. So there are numerous technologies that we've kind of shown us some slides quickly in the beginning, looking at cryo, ultrasound, external ultrasound, different applications of radiofrequency to try to shorten the procedure to as little as a 5-minute procedure, 10-minute procedure. But we don't have any of the data yet on those technologies, at least in the US, nothing outside of first-in-man experience. The initial blood pressure drops have all been 25 points systolic. As far as differences in approach to the procedure, there is some literature which has not yet been published, so I can't talk about it in detail, looking at variations of how you do the procedure that may be able to shorten the procedure and get the same type of clinical benefit. So again, just have to stay tuned for some of that, but there's a lot of interest in trying to make this easier for patients and hopefully get the same type of clinical benefit that's been seen so far.
Okay. Well, with that, we'll thank you again for a great talk. I really appreciate that. It was fantastic. Thanks.
The preceding program is copyrighted by Emory University.